We will now discuss seizures in epilepsy. So what is a seizure? A seizure is excessive synchronous activity in the brain. It's one of the few neurologic disorders where pathology comes about from increased neuronal firing. Seizures result in signs and symptoms that are dependent on whatever location they are taking place in the brain. However, we will talk about some of the characteristic signs and symptoms to look for when considering the possibility that a patient had a seizure. Diagnostic tools that detect changes in neuronal firing are useful. Usually, electroencephalography is that diagnostic tool. EEG detects fluctuations in electrical gradients on the scalp that come about from large groups of neurons producing postsynaptic potentials. When there is abnormal neuronal synchronization, that results in changes from the normal EEG pattern. However, the gold standard way to detect a seizure is to use both the EEG and clinically observing what the patient does during the event. The seizure semiology provides useful information, and the EEG alone can be indeterminate or can have false positives. There are two major types of seizures: seizures with generalized onset and seizures with focal onset. Generalized onset means that the seizure starts in bilaterally distributed networks in both hemispheres of the brain. Generalized onset seizures always impact awareness because of the widespread disruption in brain activity, including networks involved in maintaining consciousness. When captured on EEG, the recording shows discharges across the scalp. Focal onset seizures are distinct from generalized seizures in that they start at a particular location in the brain instead of starting diffusely. However, since the brain is highly connected, focal onset seizures can spread to involve the rest of the brain. So, the important differentiating factor is how the seizure begins. Signs and symptoms of a focal onset seizure are dependent on the involved areas, such as flickering lights in primary occipital cortex and ringing sounds in primary auditory cortex. Focal onset seizures can be subdivided into focal onset seizures with awareness and with impaired awareness. If the seizure starts in a network involved in maintaining awareness, or if it generalizes to both hemispheres, there is impaired awareness. Focal onset seizures show discharges localized to a particular area of the scalp on EEG before there is spread to other areas, because only that part of the brain is involved in seizure generation. So what are the different types of generalized onset seizures? We'll discuss generalized tonic-clonic seizures, myoclonic seizures, and absence seizures as high-yield examples. Generalized tonic-clonic seizures are the type of seizure that the general public is most aware of. Generalized tonic-clonic seizures have a characteristic progression from tonic stiffening to clonic shaking. In the tonic phase, patients lose consciousness and have widespread flexion with loss of posture. Eyes are usually looking upward. They then extend their extremities before entering the clonic phase, where there is widespread shaking from muscle activity. Tonic-clonic seizures usually last less than a minute. In contrast, generalized myoclonic seizures consist of widespread myoclonic jerks. Myoclonus is an extremely brief, involuntary, irregular muscle contraction lasting less than 1/10 of a second. Myoclonus can occur from neurologic insults other than epilepsy, including in metabolic derangements, after hypoxic injury to the brain, and from medication side effects, or they can sometimes occur normally. For example, hiccups are a type of myoclonus. Myoclonic seizures are usually brief and usually occur in clusters after waking up. Absence seizures are brief lapses of consciousness without loss of posture or body tone. They generally occur in children and occur upwards of 10 to 20 times per day. While there isn't stiffening or shaking, there sometimes can be repetitive stereotyped mouth movements, called oral automatisms. Absence seizures have a characteristic pattern seen on EEG that is worth memorizing. This is the 3 Hz spike and wave pattern. Absence seizures require treatment with particular anti-epileptic drugs, namely ethosuximide, valproate, or lamotrigine. Because focal onset seizures only involve part of the brain, they can result in auras from a localized seizure before they're spread to other regions. Unlike in migraines where the aura precedes the migraine, seizure auras are due to actual seizure activity. Examples of auras from focal onset seizures can include a rising sensation in the stomach, nausea, olfactory hallucinations, visual changes, and déjà vu. The exact signs and symptoms of a focal onset seizure depends on the parts of the brain involved and where it spreads. The most common location of onset is the mesial temporal lobe. Mesial is just a fancy way of saying medial. Seizures coming from the mesial temporal lobe include the hippocampus, parahippocampal gyrus, and amygdala. Mesial temporal lobe seizures commonly produce an aura of fear and nausea before the patient loses awareness and exhibits automatisms of the hands and mouth. Frontal lobe seizures can result in a Jacksonian march, which is where a focal seizure spreads through the primary motor cortex, and motor twitches spread through muscle groups that are adjacent in the motor homunculus. While the differential diagnosis of seizures is broad, let's briefly go over two of the most important considerations on the differential. Psychogenic non-epileptic seizures are not actually seizures. They are a type of psychosomatic disorder that look like seizures but don't have abnormal synchronized activity in the brain. Thus, the EEG is negative. Furthermore, patients in a psychogenic non-epileptic seizure will often behave in ways that are unusual for neurologic seizures, such as crying, blinking their eyes, or thrusting their hips. Syncope is also often a consideration on the differential, particularly in elderly patients. Syncope is a fainting spell. It occurs from transient hemodynamic disruption of oxygen delivery to the brain and can be from a number of different causes, such as orthostatic hypotension, vasovagal responses, or arrhythmias. The important differentiating factor is that syncope is brief and results in full awareness once there is return of consciousness. Factors that should push you towards considering a seizure instead of syncope include urinary incontinence, tongue biting, and prolonged confusion lasting about half an hour after return of consciousness. There are many different causes of seizures. All of these causes can alter neuronal firing and change the balance between excitation and inhibition. In general, there are metabolic causes of seizures like hypoglycemia and alterations in serum sodium, calcium, and magnesium. Fever can cause seizures, particularly in young children. Stimulant use and other drugs like bupropion can produce seizures, as well as sudden termination of alcohol use and alcohol withdrawal. Damage to the cortex from traumatic injury or from strokes can irritate the cortex and change neuronal firing, increasing the propensity of having seizures. So, just because a patient has a seizure does not mean that they have epilepsy. In fact, the majority of patients who have a seizure do not need long-term treatment with anti-epileptic drugs, particularly children who have simple febrile seizures. Epilepsy is only diagnosed when there's ongoing neurologic predisposition for having seizures. So, the cause of seizures should not be immediately reversible, as in metabolic or infectious causes of seizures. In order to diagnose epilepsy, a patient must have 2 unprovoked seizures, or 1 seizure with a high enough risk of having more unprovoked seizures. Epilepsy can be due to structural lesions that are visible in MRI, or it can occur without any visible lesion on imaging, known as MRI-negative epilepsy. MRI-positive epilepsy is usually focal onset. Fortunately, epilepsy is not always a lifelong disease. In some epilepsy syndromes in childhood, patients are expected to eventually grow out of having seizures. In other patients, epilepsy can be considered to be resolved after 10 years without seizures and 5 years off of anti-epileptic drugs. There are many different epilepsy syndromes. We'll discuss mesial temporal lobe epilepsy, focal cortical dysplasia, juvenile myoclonic epilepsy, and childhood absence epilepsy as good examples. Mesial temporal lobe epilepsy commonly causes impaired awareness even when the seizure does not generalize, because the temporal lobe is important for maintaining consciousness. Mesial temporal lobe epilepsy can sometimes be difficult to control with anti-epileptic drugs. Surgical resection or neurostimulation is sometimes used instead. Mesial temporal lobe epilepsy is frequently associated with hippocampal sclerosis, which is where the hippocampus becomes shrunken and gliotic. This may be the underlying cause of the mesial temporal lobe seizures, or it may actually occur secondarily to repeated seizures. Focal cortical dysplasia is a localized developmental abnormality of cortex. Neurons in a section of the cortex do not migrate properly and do not organize themselves correctly, so there can be abnormal activity that causes seizures. Focal cortical dysplasia does not always show up on MRI scans, so it can be a cause of MRI-negative focal onset epilepsy. Biopsy of focal cortical dysplasia shows a disorganized jumble of neurons in reactive glial cells. Juvenile myoclonic epilepsy usually has onset in adolescence, presenting as generalized myoclonic jerks, that most commonly occur in the morning. Classically, a patient will complain of spilling their orange juice in the morning from the myoclonic jerks in their arms. In addition to the annoyance of myoclonic jerks, the vast majority of patients with JME will have generalized tonic-clonic seizures. Unfortunately, despite its name, juvenile myoclonic epilepsy is a lifelong condition and requires long-term treatment with anti-epileptic drugs. Childhood absence epilepsy is a syndrome of recurrent absence seizures. Because the child appears to be zoning out, it can be often mistaken for ADHD. It is generally well controlled with ethosuximide and remits before puberty. We'll end with status epilepticus. Status epilepticus is a complication of seizures and is a neurologic emergency that can cause permanent brain damage or death. It is defined as a seizure lasting longer than 5 minutes, or multiple seizures without return to the patient's cognitive baseline in between. There are 2 main types of status epilepticus. Convulsive status epilepticus is when there is sustained motor seizure activity. Non-convulsive status epilepticus is ongoing seizure activity without motor manifestations. Non-convulsive status epilepticus causes a change in cognition. It's important to consider when working up a patient with altered mental status.